Okay, welcome back to the second session. My name is Nora Hansen. I'm from Northwestern, and this is the scientific session number 2. So our first paper is going to be presented by Danielle Carlson from the Mayo Clinic Rochester on the baseline characteristics and utility of pre-therapeutic FDG PET for pancreatic cancer.
Hello, everyone. Again, my name is Danielle Carlson with Mayo Clinic in Rochester. Today, I will be presenting our recent work assessing the baseline characteristics and clinical utility of pre-therapeutic FDG PET scans for patients with pancreatic cancer. We have nothing to discuss at this time. Pancreatic cancer is a highly aggressive, lethal malignancy due to its predilection for widespread metastatic dissemination in the majority of patients at presentation. For those patients that present with localized disease, cancer recurrence is common and poor survival is the expectation in the majority of those that undergo upfront resection. As a result of these historically poor outcomes, combined with improvements in modern chemotherapy regimens, there has been an increasing proportion of patients that undergo neoadjuvant chemotherapy prior to surgery to potentially improve survival outcomes. However, if neoadjuvant chemotherapy is to have its intended survival benefit, we must demonstrate objective and measurable responses to these treatments. Unfortunately, radiologics downstaging is uncommon, and traditional RECIST responses on cross-sectional imaging after neoadjuvant chemotherapy have not been shown to predict survival and are not considered clinically relevant endpoints of treatment success according to the NCI and NCCN. Biochemical responses like CA19-9, although useful in some patients, are inadequate in a significant proportion of patients overall, as 10% of patients are CA19-9 non-secretors and up to 30% have normal levels at baseline. The single largest independent predictor of survival after neoadjuvant chemotherapy is the pathologic treatment response. However, this is only known post-operatively. Our group recently has shown that post-neoadjuvant FDG PET can highly predict pathologic response prior to surgical resection, with the resultant metabolic responses independently predicting survival better than any other measure. As a result, the 2023 NCCN guidelines included FDG PET as an adjunctive modality to assess neoadjuvant chemotherapy responses, given the limitation and poor sensitivity and specificity of traditional response modalities. However, there is a paucity in data on pre-neoadjuvant chemotherapy in treatment-naive PDAC patients, which is absolutely necessary to utilize FDG PET for therapeutic assessment during treatment. Given our group's extensive experience with metabolic imaging during neoadjuvant therapy for patients with PDAC, we aim to describe the baseline characteristics and clinical utility of FDG PET in a cohort of pathologically confirmed and treatment-naive PDAC, comparing the results between 2 different available PET modalities, specifically PET-CT and PET-MR. We also assess the yield for identification of any suspicious FDG-avid extrapancreatic lesions, a secondary baseline staging benefit of using FDG PET for pancreatic cancer. A single-center retrospective study was conducted capturing 1,096 treatment-naive PDAC patients that underwent a baseline FDG PET imaging over the past 15 years. This included both standard PET-CT and the more contemporary PET-MRI to compare both modalities. Patients' tumors were classified as either avid or non-avid based on the metabolic activity measured with the standard uptake values or SUV levels and defined as FDG uptake of tumor compared to normal liver and surrounding non-cancerous pancreatic tissue using standard radiologic criteria. Secondary measures included CA19-9 level status and the identification of FDG-AVID suspicious extrapancreatic metastatic disease in the lymph nodes, liver, lung, and peritoneal cavity. Shown here are the patient demographics for the entire cohort and by FDG PET modality. There was a slight majority of males with no significant difference in the patient's sex between PET modalities. Patients undergoing PET-MR were slightly younger, with a higher proportion of patients over the age of 65 receiving a PET-CT scan. The primary tumor size was 3.3 centimeters, and this did not vary between PET modalities. There was a higher proportion of patients in the PET-MRI group having indwelling biliary stents at the time of PET scan. About 25% of patients in the entire cohort were either CA19-9 non-secretors or had normal levels at the time of PET scanning, and this did not differ between PET modalities. On review of the FDG activity in the primary tumors, we found that 96.3% of all treatment-naive PDAC were FDG-AVID at baseline, with the median SUV of 6.3. We also found no differences in FDG avidity of the primary tumor or the median SUV levels of the AVID tumors between PET-CT or PET-MRI. This suggests that both modalities are more than sufficient to use for metabolic response to neoadjuvant chemotherapy in the majority of patients at presentation. Overall, FDG PET identified 50% of cases with suspicious extrapancreatic disease in the entire cohort. There was a statistically significant difference noted in extrapancreatic disease detection between PET-CT and PET-MRI imaging methods, with a 60% yield in patients undergoing PET-MRI versus 44% in those undergoing a PET-CT. When looking at specific sites of extrapancreatic disease, we found that PET-MR had higher yield in 44% of an identification of FDG-AVID lymph nodes compared to PET-CT, with only 25%, and this was a significant difference. When we looked at distant extrapancreatic disease, specifically in the liver and lung metastases, there was a statistically significant higher yield of PET-MRI at 23% versus PET-CT at 17%. Finally, when assessing the yield of FDG PET for extrapancreatic peritoneal lesions, the detection rate was overall very low, less than 5%, with no significant difference between PET-CT and PET-MR. We then looked at factors that were associated with the detection of extrapancreatic metastatic disease on FDG PET. There was a non-significant association of baseline elevated CA19-9 levels on a univariate analysis. And then when assessing specific PET modalities, PET-MR was significantly associated with extrapancreatic disease detection, both on a univariate and a multivariate analysis compared to the standard PET-CT. This study had significant limitations. First, it was conducted retrospectively at a single tertiary medical center with all the associated referral and selection biases. The PET scans reviewed were performed over a 15-year time period, and this likely resulted in discrepancies in the radiologic protocols over time, as imaging technology has advanced significantly during this time frame. For those patients that had extrapancreatic disease detected on their PET scan, not all of these patients had a biopsy confirmation, thus the sensitivity and specificity could not be assessed. And finally, the study only looked at baseline treatment-naive PET scans and was not meant to assess treatment response over time. This is something we have previously published on, and both our group and others are currently evaluating in an ongoing prospective clinical trial. In conclusion, the overwhelming majority of treatment-naive pancreatic cancer is FDG-AVID, with no differences between the PET modalities. Thus, both can be used to assess metabolic treatment response to neoadjuvant therapy over time, in addition to standard cross-sectional imaging and CA 19-9 responses that are already utilized for this purpose. There is an additional baseline staging benefit of FDG PET for the identification of extrapancreatic disease, with PET MRI having a higher yield over PET CT. I would like to thank all of my co-authors, and especially my mentor, Dr. Mark Trudy, for all their assistance in this project. Thank you all for your attention.
Thanks, Dr. Carlson, for a great presentation. Dr. Trudy will be the closer, and the invited discussant is Dr. Sadra Joseph.
First, thank you very much, Western Surgical, for allowing me to discuss this paper. Thank the authors for providing me the manuscript ahead of time. It was very well done. First comment, I absolutely look forward to getting the results of the studies that are ongoing, looking at PET pre and PET post treatment. I think that has been a substantial benefit in care of pancreatic cancer patients. Two questions that I had specifically for your group, because you all are very advanced in this. Did you look at or compare your pre-treatment PET scan to EUS? That has been pretty much the standard for most of us when it comes to extrapancreatic or nodal disease with tissue diagnosis. And the second one, which is much more specific for you all at Mayo Clinic and a couple other high-end institutions, there's been a huge amount of work on the circulating pancreatic tumor cell as a predictor of outcome in these patients. Were some of those patient crossovers, i.e. they had those types of data points that you could compare them to? From a personal standpoint, would love to hear about that. That might be something for another future study in Western Surgical. Thank you very much.
Great, thank you very much, Dr. Joseph. Any other questions? Yeah, thank you.
We have another question.
Sorry, Mark.
Yeah, no worries.
Kind of a follow-up on Dr. Joseph's question. What about the ctDNA? Have you been able to compare fluctuations in ctDNA and the dynamics associated with changes in PET pre and post neoadjuvant chemotherapy? Thanks.
Dr. Talamonte.
Mark, congratulations. I always appreciate the fact that your team annually brings a great paper to the Western Surgical, and I think that's just wonderful. Timing, the MRI timing, especially the post-treatment one. When is the best time to do that relative to preparing a patient for surgery? Assuming that the first PET scan didn't show metastatic disease, when do you do the second one? And what is the second question, cost differential between CT PET and CT MRI? If I go back to my institution and say I want to start doing CT MRI instead of CT PET, I know somebody's going to ask me how much that costs.
Thanks, Mark. That was a great presentation. So I've got a question, a corollary. You know, we've published on the use of arterial phase CT and MRI pre and post neoadjuvant chemotherapy for pancreatic cancer, colorectal, liver mets, a couple other areas, showing the change in the arterialization of the tumor predicts very accurately the response of the tumor and also correlates with long-term survival probability. So have you correlated your PET findings with standard arterial phase CT and MRI, or is that something you plan to do? And the second, I'm going to really get off the rack here and probably be disinvited from this meeting in the future. Kind of a philosophical question. You know, 2/3 of the population of the world does not have access to CT or MRI. And there's currently huge strides being made in producing units that are much more cost effective, that can be dropped into a container, shipped and dropped anywhere. And with new technology, the image quality will be similar to what you're using, a 5 to 7 Tesla magnet for MRI, for example, with a less than 1 Tesla magnet. So PET scan is something that's not readily available. What do you think this translates to on a more global view in terms of how can we provide timely access to care for the vast majority of people who don't have ready access, and what would that mean to them? Thank you.
And last question, if you can say your name and your institution.
Zaid Fouad Charlottesville. I'm assuming you've had biopsy on all these patients, and my question is very specific to patients who hadn't had a biopsy. What is the performance of this imaging in patients with IgG4 disease?
Okay, so let me start off. First of all, I did want to note, Danielle is not a resident or fellow. She's not a medical student. She is a research technician in my laboratory, and this was her first clinical project that she's ever done and her first time at the podium. So I thought she did a good job. So beginning with Dr. Joseph's question, we did not compare the FDG results with their initial EUS. A lot of patients have an initial EUS biopsy elsewhere and then referred to us. So probably about maybe 15 to 20% did we have the EUS to look at specifically. Your second question, and there's been a couple about the ctDNA, that's something that we now do clinically in all patients. We have a paper coming out. We did present our peritoneal mutant KRAS results here and published as well in JACS. But now we have a large prospective cohort looking at mutant KRAS in the peripheral blood as well as the peritoneal cavity combined. And we have that highly predicts metastatic disease either at the time of initial diagnosis or over time with neoadjuvant therapy. So we did not specifically look at that in this specific cohort. We do have an R01 funded PET-MR ctDNA study that is currently accruing. We have about 90 patients thus far accrued, and some of these patients were included into that. So hopefully we'll be able to share those results at a later point in time. Other question was Chuck, your fluctuations in the ctDNA. The key thing is when you get a ctDNA, what we have shown that you have to get it before you start treatment. If you try to get some of these tests after a patient has already started chemotherapy, your yield is going to be very low. Those are both qualitative, so they're positive or negative, but they're also quantitative. You could get the quantitative number of mutant copy numbers in the peripheral blood, and you can see a significant drop in patients who tend to be responding to therapy. That's some of the people that run that lab would call us and they said, boy, it went from 20,000 to 100. Is this patient responding? And I say, I guarantee they are, and you're going to see the PET scan go from hot to cold all the time. Dr. Talamonte, you had a question on the timing of the PET. Again, this study was specifically just looking at the baseline characteristics of pretreatment PET. We had previously shown that post-neoadjuvant therapy PET scans were actually the single largest predictor of pathologic response and survival. And that's something that you could know before you make the decision to operate. We found that was better than CT or CA19-9 responses as well. So we didn't specifically look at, did they respond or not? We have a prospective trial for that. Typically, they get their initial PET. Once we have a tissue diagnosis, they all get a PET scan, they all get a triple phase scan like everyone else. We do a laparoscopy, we get tumor markers. Then they get chemotherapy, and it's typically every 2 months. Typically 4 cycles of FOLFIRINOX or 2, 3 on, 1 off Gem/Abraxane, and we repeat everything, and now we compare apples to apples. So hope that answers the question for you. The cost differential. PET-MR is more expensive than PET-CT, but you're paying for some added features. With the traditional PET-CT, they're done the FDG portion, the whole body metabolic imaging, and the CT, non-contrast CT, is done separately. And they fuse them afterwards. With the PET-MR, it's all done concurrently. The benefit of a PET-MR is you have silicone detectors in that machine that results in much higher metabolic sensitivity, which is why we're seeing higher detection of more extrapancreatic disease. It's also combined with the EOVIST contrast-enhanced MRI. So you have really great anatomical imaging, and you could see small lesions in the liver, better vasculature. And at PET-MR, you're much easier to differentiate inflammation, for example, from a bile duct stent versus viable tumor than a PET-CT, where it's sort of kind of all put together and you can't really tell. So it's significantly, probably at least 50% more expensive for a PET-MR. Those aren't ubiquitous everywhere. That being said, a lot of patients can't tolerate a PET-MR. If they have any claustrophobia, they're not getting in that machine. I've had patients scream and rip themselves out. They get really wrapped up tight. It's a tough exam to get through. You get a lot of information, but it's difficult. There's also weight limits, so certain BMI are only going to fit into a PET-MR. But we don't do PET-MR on everyone. We use PET-CT and still a majority of patients. Dr. Curley, You had asked about correlating CT, MR with path response. So we had previously also published that. We found that our PET scan was far superior to looking at CT or MR in predicting path response. And that's why we kind of went all in on PET scans, at Mayo. And then finally, the availability of PET globally, or even CT or MR. That's not something we're going to solve here. Fortunately, pancreas cancer is not a very common malignancy, even though it's one of the most deadly. Only about 60,000 patients in the United States. And fortunately, across the globe, it's actually a lower incidence than other tumors such as HCC or gastric cancer. But that's something that obviously we need to address. We're talking here about FDG PET. There's a whole new series of FAPI PETs that are now being pushed forward. Those are really frightening to look at. We also have a study that we're running at Mayo, and I told my radiologist to stop sending me the pictures because every patient has about 20 liver lesions at baseline. And then their FDG PET doesn't show anything. And so it's pretty terrifying to see that. Not unexpectedly, because we know most people do have NETs, but the imaging is going to get better, and we're going to have to interpret that imaging and have to make clinical decisions from that. And Victor, your question was about patients without a biopsy and IgG. I don't have that data specifically for you. These are all biopsy proven. Again, we don't get a PET for diagnosis. We get a PET to see if there's FDG activity we can follow, because there's a lot of misconceptions. Even though we found that PET is predictive, a lot of people said, oh, maybe it's like gastric cancer, only a third or, a third of them aren't avid. As you can see, the majority do have very avid tumors that you can follow over time. Hope that answers the questions.
Great, thank you very much. Our next paper will be presented by Dr. Chase Ugarte from Los Angeles County and USC, and is bailout procedures and acute cholecystitis, risk factors and optimal approach.
Hi, my name is Chase Ugarte. I'm a general surgery resident at Los Angeles General Medical Center. I have no conflicts of interest to disclose. While taking acute care surgery call, you encounter a 40-year-old female who presents to the emergency room with a complaint of 3 days of right upper quadrant abdominal pain. On physical exam, she has a positive Murphy sign, and her labs are significant for a leukocytosis to 12,000. On imaging, her ultrasound shows a thickened gallbladder wall and cholelithiasis. She is diagnosed with acute cholecystitis, and decision is made to proceed to the operating room for a laparoscopic cholecystectomy. Upon entry into the abdomen, this is what you find. The gallbladder is completely obscured by dense adhesions, and despite your best efforts, you cannot achieve the critical view of safety. Are there any preoperative risk factors that could have been identified to predict this exact situation? And what are your options at this point in the operation? The answer to this question requires a little bit of historical perspective. Prior to the year 1985, all cholecystectomies were performed in an open manner. After the first lap chole was performed, the procedure gained popularity, and by 1992, it was the gold standard of treatment. About 10 years ago, open cholecystectomy was the sole procedure listed as a bailout method option in the Tokyo guidelines. And since that time, surgeon comfort with laparoscopy has increased, and the laparoscopic subtotal cholecystectomy has gained traction. The two more commonly performed procedures are listed above, with reconstituting type on the left and the fenestrating type on the right. But which procedure is the most optimal type to perform in this setting? And again, are there any risk factors that could have been identified in the preoperative setting that could have predicted this difficult gallbladder? A retrospective single study published in 2022 that evaluated risk factors for bailout procedure looked at 200 bailout procedures and found the following risk factors: male sex and biliary inflammation, which included tachycardia, leukocytosis, and a diagnosis of acute cholecystitis. A systematic review published in 2015 looked at the outcomes of subtotal cholecystectomy across a number of studies and found that when compared with open bailout procedure, laparoscopic produced less risk of subhepatic collections, retained stones, reoperations, and mortality, suggesting that laparoscopic was the preferred bailout procedure type. However, a study recently published that was a multi-center retrospective study evaluated the outcomes of 87 subtotal cholecystectomies and found that when compared with open bailout procedure, laparoscopic bailout procedures had an increased reintervention rate, suggesting that actually laparoscopic bailouts were worse than open. So given this variability in the literature, it's unclear if the contemporarily preferred method is actually open or laparoscopic, and there remains clinical equipoise. We sought to identify risk factors for the use of bailout procedures in the management of acute cholecystitis, and also to compare complications and outcomes by type of bailout procedure performed. And we hypothesized that patient and gallbladder-related factors would contribute to the risk for the occurrence of a bailout procedure, and that laparoscopic bailouts would be less morbid than conversion to open. At our Safety Net Hospital, all patients with acute cholecystitis who underwent index admission cholecystectomy were included over a 2-year period. And in our study, acute cholecystitis was defined as patients with clinical signs and/or signs of inflammation in conjunction with a pathologic diagnosis of acute cholecystitis. And additionally, our only exclusion was a diagnosis of cirrhosis. Patient demographics, clinical data, and outcomes were collected and analyzed. Our primary outcome was 30-day complication rate, which included gallbladder-related and systemic complications, and our secondary outcomes included operative time and hospital length of stay. Over our study period, out of the 728 patients who underwent cholecystectomy for acute cholecystitis, 91% of those underwent a laparoscopic complete cholecystectomy, and 9%, or 69 patients, underwent a bailout procedure, which in our study was defined as any deviation from a laparoscopic complete cholecystectomy and included laparoscopic subtotal fenestrating, laparoscopic subtotal reconstituting, immediate open, conversion to open subtotal, and conversion to open total cholecystectomy. Out of those, 35 underwent open bailout procedure and 34 underwent laparoscopic. In this table, we can see that patients in the bailout procedure group were slightly older and tended to be male. And in terms of comorbidities, the rate of diabetes and renal disease was higher in the bailout procedure group. And in this table, we can see that there is no difference in the patient-reported episodes of symptomatic cholelithiasis, in addition to no difference in prior presentations for cholelithiasis. But the bailout procedure group had a higher white blood cell count on admission and increased gallbladder wall thickness, in addition to other variables that will be discussed in the multivariate analysis. We used 2 different grading scales to quantify the severity of cholecystitis. We used AAST grading scale and the Parkland grading scale. And the patients in the bailout procedure group had higher Parkland severity grade and AAST severity grade, as well as increased operative time and hospital length of stay. In terms of our primary outcomes, the bailout procedure group had higher rates of 30-day complications. And specifically in the gallbladder-related 30-day complications, there was no difference in bile duct injury among the 2 groups, which is intuitive when you think that about why bailout procedures are performed to mitigate risk of bile duct injury, which indicates that the procedure is achieving its intended goal. And additionally, the bailout procedure group had higher rates of bile leak, which is important when educating patients after a bailout procedure occurs, and notifying them that there's a higher risk of bile leak and potential reintervention. Additionally, the patients in the bailout procedure group had higher rates of surgical site infection and readmission. And out of the 10 variables used in the multivariate analysis that were significant in the univariate analysis, the following were found as risk factors for bailout procedure. T-Billy greater than 0.2, greater than a week of total days of symptoms at time of cholecystectomy, and a heart rate of greater than 100 on admission. And although these are non-modifiable risk factors, they could help inform patient consent and potentially prepare the surgeon mentally. And on subgroup analysis, when comparing open bailouts to laparoscopic, open had longer postoperative lengths of stay, but overall there was no difference in 30-day complications, which suggests that the laparoscopic bailout procedure type is the preferred method, especially when you consider unmeasured benefits such as adhesive small bowel obstruction and ventral hernia occurrence. Our study is not without limitations. The generalizability of our study is limited due to the single center retrospective nature. We didn't collect complication data past 30 days, which, the exclusion of recurrent cholecystitis or remnant cholecystitis, adhesive small bowel obstruction, and ventral hernia occurrence could have obscured the calculus when comparing type of bailout procedure. And there was heterogeneity in the approach among surgeons. Our bailout procedure type was not randomized, but instead dependent on surgeon preference, which could have introduced bias into our study. In conclusion, we found that patients with greater than a week of symptoms at time of cholecystectomy, admission, hyperbilirubinemia, and tachycardia were at higher risk for undergoing bailout. And again, these are non-modifiable, but could help inform preoperative risk assessment and patient consent. And additionally, we found that laparoscopic bailouts were preferable over open, given that these patients underwent shorter postoperative hospital length of stay with comparable morbidity. And again, there's unmeasured benefit with the laparoscopic approach. And given the variability in the literature, further prospective multi-center studies are needed. Thank you so much to the Western Surgical Association for the opportunity to present today.
Great, thank you. Dr. Morgan Schellenberg will close the paper, and Dr. Erica Sutton is our invited discussant.
Good morning, thank you. I would like to thank the leadership and membership of the Western Surgical Association for the opportunity to serve as a discussant today. I would like to thank the authors for timely receipt of this well-written and highly relatable manuscript. There can be only but a few among us who have not encountered this case or been the decision maker behind the add-on gallbladder that suddenly has both the surgeon and the patient fighting for baseline quality of life. In 2018, Tokyo guidelines published in the Journal of Hepatobiliary Pancreatic Sciences suggested that laparoscopic cholecystectomy to treat acute cholecystitis of moderate and severe grades should be performed only at advanced centers where experienced surgeons practice. An advanced center should have both appropriate personnel and facilities to manage the level of patients being managed. Surgeons should have training and experience in advanced laparoscopic techniques, and intensive care units should be available. The unique contribution of this study is to call into question these 2018 recommendations. Results analyzing laparoscopically completed cholecystectomies to bailout procedures demonstrated that patients showing signs of systemic inflammation are more likely to present technically difficult surgeries, and that laparoscopic bailout procedures have shorter lengths of stay without a greater complication rate than open bailout procedures, suggesting open cholecystectomy need not be the conversion procedure of choice in inflamed acute cholecystitis. I have a few questions for the authors. Is the reason for bailout identifiable? The sub-analysis of bailout procedures as lap versus open has produced findings consistent with what is known about lap versus open surgery. Could your data be analyzed by reason for bailout procedure? And might there be differences by surgeon or setting for choosing bailout or the method of bailout chosen? Thank you again for this new understanding of the outcomes of salvage techniques for cholecystectomy.
Great, thank you. Questions on the floor?
Yes, I'll start. Churkovich, Sacramento. Just a question regarding the role of percutaneous drainage of the gallbladder in this acute setting. I didn't hear that, and I didn't hear your greater population of patients and how often you use that technique and when.
John Russell, Albuquerque, thank you. Excellent presentation. A couple of questions. First of all, early on, you suggested that there might be some differences in terms of risk of these very difficult gallbladders in men versus women. Do you want to comment on that and whether that turned out to be a predictive factor? Second, obviously with your bailout procedures, I'm going to assume when you did fenestrating subtotals, you had an incidence of bile leak that was higher than those patients who had laparoscopic complete or open complete cholecystectomy. What was your management of those? Was it expectant, watch the drain, persistent, then do a stent, or have you adopted a more aggressive approach towards using stents in those patients? Thank you.
Madura Phoenix. I'm wondering, did you consider a conversion to an open operation bailout, regardless of whether you completed the cholecystectomy in an open fashion? Because that's going to be a different population of patients than the patients we're now seeing coming in with recurrent cholecystitis after they supposedly have already had their gallbladder taken out.
Morning, Tyler Hughes from Salina, Kansas. Having lived in both worlds, all open and all laparoscopic, one thing I thought was missing from this is examining the surgeons who are doing the operations. Were they trained before or after 1990, which is the inflection point for laparoscopic surgery, and or what the training paradigm might have been for bailout procedures? Because after all, what you know the best is usually the best result.
Great presentation, great slides, great data, great presence. So good job. My question has two questions. One is your conclusion that a laparoscopic is preferable over open. Your data didn't really show that, other than length of stay, because it's an open and that's not really modifiable. So can you really make that type of a statement based on your data? And second, you did acknowledge that you didn't have long-term complication rates. We're all of us here have probably seen remnant cholecystectomy after some of these subtotals. But what about other interventions, ERC, drain studies, et cetera? Are they higher in one group or the other? Thanks.
Last question.
Dan Margulies, Los Angeles. Thank you for studying this really important work. And my question has to do similar to the previous one, which is that if the patient was converted to open and then the gallbladder was actually completed, in terms of taking it out entirely, is that excluded from your data, or is that considered part of the bailout procedure?
All right. Thank you so much, everyone. Thanks to the program committee for the opportunity to present our study here today, and thanks to Dr. Sutton for reviewing our work and providing her questions well in advance of the meeting. The reasons for the bailout were unfortunately not clear in this retrospective study, but we've moved into a prospective phase of data collection and can make sure that we capture that variable with the prospective portion of the study. As for your second question, Dr. Sutton, there may certainly be some differences by surgeon, fellowship training, et cetera. I can elaborate that the majority of surgeons who take emergency general surgery calls at our institution are ACS fellowship trained, and that there are virtually always trainees present at the case, but we can certainly delve into this concept further and add more details to the manuscript. As for the questions from the audience, to Dr. Jurkovich, we did not examine percutaneous cholecystostomy tubes in this study. To Dr. Russell, to answer your first question, we did not look at sex as a predictor of outcomes in the study. Reintervention rates, however, were comparable between open and laparoscopic bailout procedure groups, and the management of bile leaks was not standardized and was pursued at surgeon discretion. To the third speaker, yes, we considered conversion to open a bailout procedure. To Dr. Hughes, your point is well taken, and we can certainly go back and examine further details about the surgeon performing the operation, exactly like Dr. Sutton suggests as well. To the next question, I think your point's, again, well taken. I think certainly with a retrospective observational study, this is hypothesis generating and not sort of proving our point, and certainly further work will be needed into this area. And lastly, to Dr. Margulies, yes, the patient you mentioned would have been considered would have been considered in the bailout procedures group. Thank you so much.
Great, thank you. The last paper of this session is going to be presented by Dr. Ahmed Abdelkarim from the University of California in San Diego, post-operative outcomes in anemic patients undergoing carotid revascularization.
Thank you for letting me presenting. we have no disclosures. Anemia is a universal concern affecting more than 1.9 billion worldwide. Preoperative anemia is considered a risk factor for morbidity and mortality after vascular procedures, especially in elderly. Carotid artery stenosis, responsible for 10%, around 10% risk of ischemic stroke, is considered highly prevalent in the same patient population, and there is a limited research investigating the optimal method of revascularization in this high-risk group. In 2013, a retrospective analysis using an NSQIP dataset found that for each percentage drop in hematocrit, there is around 10% increase in the risk of 30-day mortality following carotid endarterectomy. We refer it to as CEA. A more recent analysis using the same dataset found that anemic patient had around 3-fold increase in the risk of 30-day mortality after CEA. Our team previously studied vascular quality initiative dataset to study the effect of anemia on carotid revascularization. And we found that there is high risk of 30-day mortality after CEA and carotid artery stenting. Now we come to the comparative outcomes between the three methods of revascularization. In the previous paper, we didn't study the transcarotid artery revascularization, since carotid artery stenting was mainly performed using transfemoral approach. Given the recent adoption and expansion of transcarotid artery revascularization, which we refer to as TCAR, in the last 5 years, and with the recent decision by CMS to expand transfemoral carotid artery stenting to standard risk patients, it became imperative to study the comparative outcomes of the three procedures, especially in patients with high medical comorbidities like anemia. In order to achieve that, we will compare the three procedures in anemic patients to determine which one is associated with the most favorable outcomes, hoping this will aid patients and surgeons in their decision for intervention. We retrospectively analyzed anemic patients undergoing CEA, transfemoral stenting, and TCAR in the Vascular Quality Initiative dataset between 2016 and 2023. Vascular Quality Initiative database is prospectively collected from more than 1,000 centers in North America, including more than 1 million patients. We defined anemia according to World Health Organization guidelines. We included only anemic patients with carotid atherosclerosis, intimal hyperplasia, restenosis. We excluded those with dissection, traumatic lesion, more than one lesion, and those with missing data. Our primary outcome included 30-day mortality, major adverse cardiovascular events, including in-hospital stroke, death, MI. Our secondary outcome included those outcomes separately, and reperfusion syndrome, and prolonged length of stay defined as post-operative length of stay more than 1 day. We used the usual statistical analysis method, and we adjusted for the potential confounders using multivariate logistic regression. And then we included more than 60,000 anemic patients. Of those, 62% underwent CEA, 14% underwent transfemoral stenting, and 24% underwent TCAR. Transfemoral stenting group was more likely to be symptomatic. TCAR patients were more likely to be older, white, and Hispanic, and they were more likely to have hypertension, coronary artery disease, chronic kidney disease, higher ASA classification, while transfemoral stenting group was more likely to be smoker, have congestive heart failure, diabetes, and COPD. TCAR group was more likely to be on preoperative medication. And they were more likely to have prior CABG PCI and underwent more contralateral carotid revascularization. On the other hand, transfemoral stenting underwent more ipsilateral carotid revascularization. They had more contralateral occlusion and severe ipsilateral stenosis. In univariate analysis, compared to transfemoral stenting and TCAR, CEA had the lower rates of 30-day mortality, stroke death, major adverse cardiovascular events, and reperfusion syndrome. TCAR group had the lowest rates of prolonged length of stay. After adjusting for more than 20 potential confounders, in anemic patients, we found that TCAR had the lower rates of 30-day mortality in comparison to CEA. On the other hand, transfemoral stenting was associated with almost 3-fold increase in the risk compared to CEA, and TCAR was associated with half the risk compared to transfemoral stenting. Regarding major adverse cardiovascular events, there was no significant difference between TCAR and CEA. On the other hand, transfemoral stenting was associated with almost 2-fold increase in the risk, and TCAR was associated with 40% less risk than transfemoral stenting. Regarding our secondary outcomes, TCAR was associated with lower risk of myocardial infarction and prolonged length of stay. Transfemoral stenting was associated with a higher risk of stroke death, reperfusion syndrome, and prolonged length of stay. And TCAR was associated with a higher risk of the same outcomes in comparison to transfemoral stenting. The limitations of our study are similar to any retrospective study, with the possibility of confounding and selection bias, and the fact that we only included in-hospital data, so our results may not be generalized beyond that time point. In conclusion, our results show that in anemic patients, transfemoral stenting was associated with the worst outcomes. On the other hand, TCAR and CEA were similar, and TCAR was even associated with lower risk of in-hospital myocardial infarction, despite the fact that TCAR patients were more likely to be older, have more medical comorbidity. Given the recent CMS decision to expand carotid artery stenting to standard risk patients, I think that this decision should be reevaluated, and more future prospective study will be needed to validate our results. I'd like to thank my co-author and my mentor, Dr. Malas, for the continuous support. Thank you.
Thank you. So Dr. Malas from the University of South California, San Diego will be the member closer, and the invited discussion is Dr. Mansour from Spectrum Health.
Thank you very much. A very nicely presented paper. So Dr. Malas and his colleagues has been interested in outcomes research, and he's been particularly focused on TCAR and carotid interventions. The largest randomized trial on carotid intervention was published, it was a CREST trial published in New England Journal of Medicine 13 years ago. And that showed that transfemoral stenting and carotid endarterectomy were basically equivalent. It also showed that the risk of myocardial infarction, or the incidence of myocardial infarction, was higher with carotid endarterectomy versus stenting, but the risk of stroke was higher in carotid stenting than it is with carotid endarterectomy. Important to keep in mind. So today's paper still asserts the relative superiority of CEA in preventing stroke, and that TCAR is much better than transfemoral carotid stenting because it avoids crossing the arch and crossing the lesion, and both those things are associated with an increased risk of stroke. TCAR protects by flow reversal and direct access to the carotid artery in the neck. So the authors find that anemia contributes to postoperative outcomes. And I have 3 simple questions that will help us manage our patients. Do you think that anemia is a surrogate for the systemic disease in a given patient, and that makes it riskier for carotid procedure? My second question is, what would you do if you plan an elective carotid endarterectomy and you find that your patient is anemic? So should you delay, or would you proceed? And then finally, what procedure would you choose if you had to do an urgent procedure on a symptomatic patient? Would it be a carotid endarterectomy or a TCAR? Thanks very much for sending the manuscript ahead of time, and thanks for the Western Surgical Program Committee for asking me to discuss this. Nice job.
All right, this paper is now open for discussion from the floor.
I have a question. Have you looked at the same thing in patients who are not anemic and compared those in your data?
Okay. Well, thank you for the Western Surgical Association for accepting our paper. Really honored to be here. And I want to highlight Ahmed's work. Also, he takes full credit for this, and he's applying for surgery. So hopefully you guys can remember him. You know, as far as the, my only disclosure is really my passion for carotid revascularization and preventing stroke. That's what I spent for the last 15 years researching. And I was in a place where I end up not by choice being the carotid stenter at Hopkins. And I continue to love doing carotid endarterectomy all the time. So we did a lot of research showing the differences like Dr. Mansour is referring to show that carotid endarterectomy is actually safer even in high-risk patients. I want to kind of bring to your attention for the non-vascular audience this very important thing that just recently happened almost 2 weeks ago, where CMS actually approved transfemoral stenting to be done on any patient. In the past, you had to have higher risk criteria to undergo transfemoral stenting. As of 2 weeks ago, any patient can get transfemoral stenting, whether they're high risk or not, in any center in the United States. Also in the past, you have to be center of excellence, submit your data, and have very low stroke rate to perform carotid stenting. This is not the case anymore. So we're going to see a lot of strokes, and we're going to see a lot of complication over the next few years because anybody now going to be able to do transfemoral stenting on any patient, not to even dive into the inappropriate and overuse, because nobody can monitor, are these patients even have high-grade stenosis? So this is a very passionate topic to me, even though I've done probably a lot of transfemoral stenting, but I think it's appropriate in appropriate patient. And then with TCAR now, we have this finally a procedure that can avoid the arch that, like Ashraf mentioned, and avoid the lesion and create this amazing flow reversal. And we've seen so far, to answer your question first, you know, we've seen a very similar data in non-anemic patients. So we know so far, at least in retrospective analysis, and every TCAR patient done in this country has to be registered with the Society of Vascular Surgery, and outcome has to be reported in a VQI, which is not the case for transfemoral stenting. So we have seen now we have up to 40,000 TCAR, and so far the outcome is similar compared to CEA as far as stroke and death, while it's half that compared to transfemoral stenting. So to answer the 3 questions that you answered, which I think, thank you for, you know, asking them, they're very important clinical questions. Number one, of course, you know, I agree with you. It's going to be a marker. Anemia is going to be marker for being sick and old and have other comorbidities. And that's always what I teach my fellows. There's always residual confounding, no matter what you do, even if you do propensity match score. We did the best we can. We adjusted for 20 covariates. A lot of it is age and demographic and all the comorbidity we can think of. And we still have this persistent you know, effect of anemia. So we think it's real. And it's not really surprising because it's been shown also in non-vascular patient in many other studies. The second question is, you know, if you have an asymptomatic patient anemic, would you wait? And absolutely yes. If the patient is asymptomatic and have high grade, there's even debate today whether we should even revascularize them, period. So CREST-2 is ongoing now. See is medical management is best. They're done with all the carotid endarterectomy now. They're doing finishing the stenting arm. We will see. And I think, you know, appropriate medical management, aspirin, statin, you know, and waiting until you can correct the anemia. The problem is you probably can't correct all anemic patient. And our prior research showed that if you transfuse them, actually they do worse. So unless you can treat them medically. The final most important question really, what do you do if you have a symptomatic patient? Our research and other people have found that the best window to operate on symptomatic patient is between day 2 and 14. If you operate in the first 48 hours, the risk of stroke is very high. If you wait after 14 days, the benefit of carotid revascularization dramatically drop. So that window is important to do the carotid revascularization. And I think, given that data, it seems like TCAR and CEA is similar, maybe less risk of MI with TCAR. I would say I'm still a surgeon. I love carotid endarterectomy. I'm biased to it. So I would say if the patient is a good risk for CEA, should get a CEA. And if they're truly high risk, and this high risk is very debatable, most of it is not really high risk. It's in the eye of the beholder and the experience of the surgeon. But I think if they're truly high risk, TCAR seems to be the better option than transfemoral. And thank you for inviting us.
Great, thank you. So next is going to be our presidential address. I think we have to just wait a few minutes, maybe to stretch until Dr. Shoup's family gets here.